Good afternoon, everybody. Welcome to another day in our series for the Health for the World lecture series. So this afternoon, I have the pleasure of introducing one of the senior fellows, IR fellows in the Muhimbili University Health and Allied Sciences University. His name is Dr. Zaid, and he'll be doing the journal club this afternoon on embolic agents in IR under the faculty of Dr. Joseph Kubilion. Thank you very much. So I'm sure it's going to be an interesting one this afternoon. Please, if you have any questions or comments, please feel free to type them in the comment section. Dr. Zaid, you're welcome.
Thank you, Fonzie, for a very good introduction. So welcome, everybody. So I'll be taking you through one of the journal that reviewed embolics in materials in interventional radiology. So this article was reviewed by the American Journal of Radiology. So this article was reviewed by was reviewed and presented in the American Journal of Radiology, and it's about embolic materials in IR. So welcome. So this was a case-based approach on common embolic agent used in vascular interventional radiology. So the objective of this review is for all of us to familiarize ourselves with the most commonly used embolic agents in interventional radiology and discuss an approach for selecting among different embolic agents. So sorry, we had a bit of internet problem. So introduction. So percutaneous transcatheter embolization is a well-established, commonly performed minimal invasive therapeutic option used for a variety of clinical conditions. The goal of embolization is to occlude or decrease blood or lymph flow in arteries, veins, and lymphatic ducts. Since the introduction of autologous blood clot used in the 1970s, many sophisticated embolic agents in conjunction with advancement of imaging and catheter technology have been developed and helped a lot in the interventional radiology. So each embolic agent has unique characteristics that make it desirable in certain clinical situations and less useful in others. No single embolic agent is suitable for all indications. So we'll be seeing like different cases, different scenarios, and how we choose different embolic materials to reach our goal of embolization. So embolic agents can be classified in many ways. They can be classified in physical states, like solid versus liquid. They can be classified as mechanism of action, mechanical or chemical. They can be classified as their origins, autologous, biosynthetic, or synthetic, and most importantly, embolic agents can be classified in duration of occlusion, which is the most one that we're using. So the category is divided into permanent and temporary embolic materials. So like you can see here, this table with the classification of agents based on duration of action. We have temporary embolic materials like gelatin sponge, which is gel form, which can be obtained in sponge form or in powder form, but commonly use it in sponge form, and others like oxidized cellulose or microfibrillar collagen. And then in the group of permanent, we have non-absorbed microparticles, which are like PVAs and TGMs, which is the class of embosphere. Embosphere is here. And then we have mechanical agents like coils and detachable plugs. So coils can be pushable, injectable, or detachable. And then we have liquid agents. So the group of sclerosant, we have ethanol and sodium tridecyl sulfate. So these one here are the most commonly used, ethanol and sodium tetradecyl sulfate. So temporary embolic agents. So there'll be a situation that you would want to temporarily embolize a blood vessel. And this is where you use gelatin sponge, which is gel form, or oxidized cellulose and microfibrillar collagen. So we'll be talking about gel form since this is the one which is most commonly used. The oxidized cellulose and the microfibrillar collagens, these are very difficult to prepare. So most people prefer to use gel form. So gel form is most widely used temporary embolic agent. It is absorbable by a prosthetic material available as a block, which can be a sponge or a sheet, or as a powder. It provides vessel occlusion, typically lasts for 3 to 6 weeks. It can be available in the gel form product particles can be available from 10 to 100 microns. Gel form sponge is relatively inexpensive, widely available, and easily modified to size of the target artery. So most of the time we like to use gelatin sponge in contrast to powder particles because powder particles can give you severe infarction. So we'll be talking about the gel form. So gel form sheet can be cut into plates of desired size, usually from 1 to 3 millimeter, and mixed with contrast materials and prepared as a gel form slurry. But we can also see how gel form is made as torpedoes, and we use gel form slurry and where we use gel form torpedoes. So all we use gel form slurry is when you have a patient with a postpartum hemorrhage or traumatic fracture, where there are multiple bleeding sites from the different iliac artery branches. So in this case, you would want to temporarily occlude or embolize the internal iliac artery, since you can go in different vessels. If the bleeding is in the iliac arterial branch cannot be selectively capitalized, you can use also a gel form slurry. We can use gel form slurry in treating bleeding due to gastric and duodenal ulcerations that can be managed medically after embolization. So gel form torpedoes. So the way that you make gel form torpedoes, you have like a small sheet of gel form, you roll it and you introduce it into the syringe nozzle, and then you push it into a vessel by normal saline. So torpedoes are used for occlusion of large vessels. They can also be used in an existing sheath for embolizing needle or catheter tracts after procedure, most commonly after portal vein embolization or after liver and lung biopsies in a patient who are high risk of bleeding. Now, so those were temporary embolic agents. So now we can talk about permanent embolic agents. Most modern embolic agents produce permanent vessel occlusion, and they can be classified as non-absorbable microparticles, which you have PVAs and embospheres. And then you can have mechanical agents like coils and plugs. And then you can have liquid agents like sclerosant, ethanol, or glue. So what are the PVAs? So PVAs are particles derived from the plastic sponge, available in a wide range of diameters from 45 to 1,200 microns. So how the way the PVAs work is they adhere to the vessel wall and cause inflammatory reaction. And at the end of the day, they cause vessel fibrosis, and you achieve your embolization. So PVAs are used for embolization in patients with tumors and uterine fibroids, and in those with hemoptysis from chronic inflammatory disease. So there are some PVAs combined with the chemotherapeutic agents like doxorubicin. So these ones are used for the treatment of HCC in the procedure called TACE. So the major disadvantage of PVA's particles is their tendency to aggregate and clump together, which can occur in a vessel more proximal than intended, and then you have undesired or not desired embolization. So this can occur in the catheter itself, which can cause, which will cause the clogging of the catheter. It can occur in the catheter hub, which can lead in non-target embolization while the catheter is being flushed with saline. So theoretically, clumping of PVA particles can be avoided by proper suspension, dilution, slow infusion, and resuspension just after injection. These are less likely in practical world. So there are some PVAs which are made to avoid the problem of aggregation and clumping together, just to escape the non-target embolization. So bead block from Terumo is a biocompatible deformable PVA that has hydrogel, which is hydrogel tinted, and it is deformable up to 30% of original diameter, just to traverse or to go through the tortuous vessels and avoid the clumping together. So the other group, the other type of permanent embolization in non-absorbable particles are the triacyl gelatin microspheres, which most of us commonly known these as embospheres. So these microparticles, in relation to, in contrast to PVAs, these ones are precisely calibrated, and they are available in 6 sizes, ranging from 40 to 1,200 microns. Their hydrophilic nature prevents aggregation and provides more predictable occlusion than PVA. So in addition, they have inherent elasticity, which also allows temporary deformation during delivery through a catheter to avoid non-target embolization. The size of microsphere selected should be actually be larger than the PVA's particle in any situation, because these ones are elastic, like I said before. So you need them to be more, this one, they cannot aggregate or clump together. So you need them to have a bigger size than the PVAs, just for them to achieve the same desire of embolization. The indication for microsphere use are the same as for those of PVAs. Now, UTM-90 is one of the very smallest microspheres. It's a pure beta emitter, which is they come into 20 to 60 microns, and they are used in radioembolization of hepatocellular carcinoma. Now, during the publishment of this article, there are other 2 types of microspheres which we are still on study. So one of them is embolization. So the important characteristic of embolization is it is well calibrated, which results in tight size distribution. And the other ones are imageable beads, which are like PVA hydrogel microspheres, which they are loaded with ethanolized oil, a gibet, to make them visible while you're doing procedure, because you want to see these particles where you're doing a procedure. So these imageable beads, you can actually see them in CT or in fluoroscopy during the procedure. So the other group of the permanent embolic materials is mechanical embolic agents. Now here we're going to talk about coils and plugs. So we can start with coils. Coils are manufactured in many configuration, sizes, and produce permanent vessel occlusion similar to surgical ligation. Generally made from either stainless steel or platinum. But those which are made of platinum, they are good because they are very malleable, but then they are very expensive. So most of us prefer to use the stainless steel coils. So they're commonly available in 035, 038 inch, and 018 as micro coils. And they're available in a length of 1 to 300 millimeter and diameter of 1 to 27 millimeter. Coils can be straight, helical, spiral, or complex 3D shapes. Made more thrombogenic by coating them with polyester fibers. Now, the effective vascular occlusion of coils depends on the coagulation status of the patient, because it depends on the patient's ability to form thrombus. So it is less likely to use coils in patients who are highly bleeding, who are in high bleeding risk. So coils should be at least 20 to 30% larger than the target vessel. Oversizing can cause coil being not able to form completely, so which can cause cuff displacement and non-desired embolization. And then if they are undersized, they are prone to distal migration and also non-target vessel embolization. So embolization coils can be delivered to the desired site by either pushing, using a saline flash, or using dedicated detachment system or coil pushers. So the pushable coils and ejectable coils, these are the ones that are commonly used. They are very user-friendly, quick deployed, and relatively inexpensive. The major disadvantage is their ability to be quickly retrieved once deployed from the catheter. So then we have liquid coils. So the liquid coils are extremely soft and non-fibered platinums. These ones, they come in very small sizes. You can have even 0.08 inches. They can negotiate tight bends and tortured vessels, and they can conform to space into which they are injected. The detachable coil, this can be recaptured. So this one, in comparison to the pushable coils, these ones are good because they can be recaptured and repositioned several times before the release, which allows more precise placement. But these ones are more usually in the intracranial interventions, and when you have a very high vascular flow, which increases the risk of the coil migration. So even if they migrate, you know that you can retrieve them. Generally not necessary for peripheral interventions. Variety of controlled release mechanisms exist in these detachable coils, like mechanical, hydrostatic, or electrolytic. Detachable coils, the major disadvantage of the detachable coils is their longer procedure time and they are very expensive. So now we can talk about amplatz vascular plugs, which most of us know them as plugs. Plugs are permanent mechanical embolic devices constructed from self-expanding nitinol mesh. So plugs are safe and effective embolization devices and are especially suited for precise deployment in high flow, relatively straight vessels when there is possibility of coil migration. So here you can use this, or you can use detachable coils. So like detachable coils, plugs can be recaptured and repositioned for precise deployment. So plugs need to be oversized by 30 to 50% of the vessel diameter and may require distal placement of a 5 to 8 French guiding catheter. And then plugs are relatively expensive, but significantly reduce procedure time in relation to detachable coils. So they are non-fibered. Embolization requires patient's ability to form thrombus and complete occlusion, just like coils. So plugs have been commonly used in patients with the pulmonary arteriovenous malformation, where you don't want to use small particles which can migrate and cause non-target embolization. And then they can be used in occlusion with splenic artery, portal vein, and persistent varices after TIPS placement, and occlusion of internal iliac artery before auto-iliac stent grafting. So the other group of permanent embolic materials are the liquid embolic agents, which their use have been increasing nowadays. However, during administration, liquid embolic agents can be difficult to control. So these ones should be administered with a highly and very expensive operators. And they do not depend on patient's coagulation system for complete occlusion. and that can be effective even in a patient with severe coagulopathy. So the most commonly liquid embolic agents that we use are the alcohol, which is ethanol, sodium tetradecyl sulfate, and sometimes the glues. So absolute alcohol, which is ethanol, most commonly used sclerosing and cause protein. So the way they work is they cause protein denaturation, which leads to endothelial damage and permanent vascular occlusion. So when you're using this, it is very important sometimes to use the latex occlusion balloon catheters, which they offer the control of the flow of the ethanol, and they can prevent reflux of the ethanol, and they can keep ethanol in place for a few minutes, allow the ethanol to interact with the endothelium and cause the desired embolization. So ethanol is indicated in renal tumor ablation, portal vein embolization before partial hepatectomy. Sodium tetradecyl sulfate is an ingredient that is used in treatment of the pelvic congestion syndrome, variceal, and venous malformation. Now we have seen all of these embolic materials in different groups. Now you should know the algorithm for choosing these embolic materials in different scenarios. So these different scenarios, they actually depends on the vessel size that you're going to occlude. It depends on duration of the occlusion desired, whether you're going to use it permanent or you're going to use a temporary embolic material. Also, it depends on need of the tissue viability. And then lastly, it also depends on clinical condition, whether you have a stable patient or unstable patient. So we'll see how this works. So the vessel size. Large vessels such as feeding artery in pulmonary AVMs or splenic artery, we usually like to embolize them using large coils or vascular plugs. So, but in contrast for small vessels, like bleeding from the gastric erosions, when bleeding artery is not angiographically visualized or tumors. So here you're going to use the small, the microparticles like PVAs and embosphere. Now, duration of occlusion, if you have a procedure or a patient who you want to embolize, but then that you want that artery to future recanalize in a temporary embolization, most of the time we usually use gel foam, but the other agents, most of them are permanent. So tissue viability, with the exception of tumor or solid organ ablation, maintenance of tissue viability is usually desired. So most organs have some degree of dual vascular or collateral blood supply that allows safe embolization with permanent devices such as coils, plugs, and large particles. Now, tissue infarction is generally desired in tumor embolization. The use of small particles, say less than 300 microns, result in occlusion due to the potential collateral pathways and may lead to tissue death. Sclerosant and liquid adhesive embolic agents can also be used in tissue necrosis when it is desired. Now, so depending on clinical condition, how are we sometimes forced to choose our embolic materials? A patient with, let's say a patient with a pelvic hemorrhage from multiple sources, and the patient is hemodynamically unstable. This is where you like to use the temporary embolizing material like gel foam. But if you have a hemodynamically stable patient, you'd like to want to plan at least for a more time-consuming, super selective procedure, which you can use coil embolization. Coil embolization can be done here. So before surgical splenectomy or in trauma, patient with the intrasplenic aneurysm, here you'd want to do proximal splenic embolization, which is effective with using coils or plugs. In contrary to this, patient with the splenic tissue infarction, using particles is desired for hypersplenism and thrombocytopenia. So now we have different cases, and we'll see how they chose their embolic materials. So case one was a 42 years old male with increasing abdominal pain after trauma. So this is a patient who was in trauma, so they would anticipate a splenic laceration or splenic trauma where the patient can have multiple pseudoaneurysm. So study was done. So this was the splenic arteriogram with a Cobra catheter, which showed multiple small aggregated area of focal areas of contrast, which they were thought to be pseudoaneurysm. And then here you can see the spleen is slightly pushed medial. So this was a hematoma. So in this case, they decided to go in the proximal part of the spleen and use coils for embolization. And then you could see the distal part of the spleen, it's getting vessel, and this is because of the other side, collateral vessels that are coming from other circulation. So in this case, they wanted to do a proximal splenic embolization, in contrast to patients who have hypersplenism or thrombocytopenia, or you want to plan a very super selective procedure to embolize the spleen. So the other case was a 72 years old male with cirrhosis after the initial medical measures had failed. The patient was presented with acute variceal bleeding, and then TIPSI was done. So this is what was portovenogram, which was done after TIPSI. And then they formed these two major gastric varices from the left gastric vein and the short gastric veins. So in this case, they went in, they put in plugs in both veins. And then you can also see here there's a filling defect, which was with a thrombus. So they went in, put in plugs in both veins, and then they put a stent in the portal vein where there was a thrombus, and then they did the portovenogram, which shows disappearance of those highly dilated gastric veins. So the third case was the 80-year-old woman who was hypertensive after massive lower GI bleeding. So splenic arteriogram was, superior mesenteric artery arteriogram was done, which showed a focal area in the right colic artery. There was an area of extravasation here, and so this was a focal area of bleeding. And then they went in to super select the right colic artery, and then they could well visualize the area of bleeding here. So they decided to use microcoils here, and then you can see no area of bleeding after coils placement. So in this case, they decided to use microcoils. And the fourth case was the patient who was 48 years old man with stage 4 sarcoidosis and the left upper lobe mycetoma. And the patient was presenting with the recurrent hemoptysis. The patient did bronchoscopy, which showed the left upper lobe, the source was in the left upper lobe. So they went in, the left bronchial arteriogram was done, which showed a very dilated and tortuous left bronchial artery. And its distal, distal branches, they were also seen to be, first of all, highly vascularized, and then they were seen with large caliber. So in this case, they went in and then they used the, sorry, what do they use? So in this case, no, it doesn't go there. Oh, so in this case, they used ethanol, which was combined with the ethiadol, the gibbet one that you can see where you put in your contrast. And then So in this case, they used ethanol, which was combined with the thiazole, which is called gibbet, to see where they embolize. And you can see here stasis was achieved, and those vessels are seen without, sorry, I had a bit of a problem with the internet connection, but I was almost finishing. I had only one last case to finish this talk. So where is my? Hello, vipi tena hapa? Wapi? Hapa. Okay. So the fifth case was the 43-year-old woman with an enlarging 7 centimeter right upper pole exophytic renal angiomyopathy. So a selective renal arteriogram was done, which showed a highly vascularized area of a confirmed angiomyopathy region, which showed it was very highly vascularized. So they went in, and then in this case, they also used ethanol, which was combined with the gibbet. And then you can see the cast of the small vessels here. It's because they used the gibbet. And then in the late images after embolization, you could see there was a revascularization of the kidney, but the tumor was devascularized. Then the sixth case was a woman developed right chylothorax following surgery for a mediastinal abscess. And this chylothorax was a high output because it has like 1,100 cc per day. So in this case, the access was gained on the one of the inguinal lymph node, and then they injected gibbet. And then in the middle image showed the late image that you can see the contrast in the thoracic ducts and the cisterna chyli, but also there's contrast extravasation along the catheter, that the tube, that the right lung tube, tube that was inserted in the lung because of the chylothorax. And then the late images after embolization. So in this case, they used microcoils just to give a matrix for glue. So they used microcoils, the glues, and they also used the ethanol for you to see them. So in this case, these regions are the regions where you could see those the microcoils glue and then the gibbet where they did the embolization. Internet again. Oh, shit. One last case. I think it's the internet. Okay, so the last case, you can stay here, man. So the last case is a 65-year-old female pedestrian who was hit by a car, and CT showed the bleeding in the left gluteal region. So in this case, they selected a left internal iliac artery, but then they showed in the peripheral a focused area of contrasting allocation with those. So this was an anticipated bleeding. And then the late images, cone view of the late internal iliac artery access was done. And then so that focused area that was shown in the previous image, right now you can see enlarged, but they can also see another focal area of contrast exacerbation. So this appeared as multiple bleeding area. And then they decided to go and embolize the internal iliac artery by using gel foam because they could not get into one of these, in each and one of these branches. So conclusion, A spectrum of embolic agents is available for use in vascular and non-vascular embolization. Having a comprehensive understanding and practical knowledge of these agents is essential for optimal and safe use of different scenarios. A thorough knowledge of their mechanism of action and adequate training in their use are important to minimize side effects and avoid potential catastrophic complications such as non-target embolization. So this is the end. So people are welcome for comments, critiques of this paper, and questions.
Okay, I just want to make a couple comments. Can you guys hear me?
Yes.
Okay, so like I said, I told you guys when I was there, for splenic embo, remember, unless you see a very single focal bleeder and you're trying to be cute and practice your microcatheter skills, the whole point is to decrease the pressure head. And therefore you just drop a proximal plug and be done with it. I don't recommend, again, using gel foam in the spleen. People do it. I have seen plenty of cases where the spleen infarcts. You're trying to stop a bleed, but now you have infarcted the spleen itself and you get an abscess. So I do not recommend gel foam. Now, granted, if it is all you have and it's a life or death situation, sure, that's fine. But otherwise, I just recommend the proximal coil and you're done with it. For UFI, pretty much the gold standard is 500 to 700 micron embospheres. PVA, you get the corresponding size. So that's the size you're looking for. Too big, you may get incomplete necrosis, but it might be a little more pain because you'll have more uterine infarction itself. For kidneys, remember, that's an end organ. So you really just want to use a coil whenever possible. Again, everything I'm saying excludes a life or death situation. In those situations, everything's off the books. You do what you need to do. But if you see a small bleeder, a little AVF after a biopsy, whatever it is, you try to be as selective as possible. And if you need to be a little less selective to get the job done, generally that's okay. They have two kidneys, and if you're killing, 30% of the kidney instead of 10%, if you could be perfect. If you can be perfect, be perfect. But if you can't, don't, you do what you need to do to get the job done. PVA, I think you guys have that a lot more than embospheres. Be very aggressive with your resuspension between injections. So I recommend a 3-way stopcock, and you put the 1 cc medallion in line with the catheter, and your reservoir will be the perpendicular syringe, 10 cc's or whatever. And every time you're doing it, aggressively flush back and forth to resuspend the PVA and break up the clumps so you can have as uniform an embolization as possible. Gel foam, no one's really using the powder anymore. It's too small. It causes infarction. When you're mixing the gel foam from the sponges with 3-way stopcock, if you just mix back and forth a couple times, you're going to have big particles. The more and more you do it, the smaller and the smaller. For tips for varices, if it's esophageal, you can probably get away with just coils or maybe even nothing if the tips is good. For gastric varices, they bleed at lower pressures. So you do need to embolize these, in my opinion, even if you don't see them after the tips, which would suggest they're decompressed, but you'd be surprised how often they can stay patent. And so for these, I don't just drop a coil myself. I want to embolize the entire network. And so I'm doing a mix of gel foam and SDS, and then you back it up with a coil. And for GI bleeds, you can infarct colon pretty easily if you try to. Never should you be using spheres or gel foam in the bowel. It's almost always coils and microcoils. It just doesn't have the backup blood supply. The one exception would be rectum. Rectum has 3 blood supplies: superior, middle, and inferior rectal arteries. So if you have to use something there, you have more bandwidth to get away with it. But that being said, you should really never use particles in bowel. It's really just coils and microcoils. And that's it.